Hello, welcome to today's webinar, Neighborhood Nursing, How a Universal Community-Based Primary Care Model Cares for Adults with Complex Needs. This webinar is hosted by the Better Care Playbook, which is an initiative of the Center for Healthcare Strategies, and it's made possible with the support of the Seven Foundation Collaborative. My name is Logan Kelly. I'm a Senior Program Officer at the Center for Healthcare Strategies. And on the next slide, before we get started, I'll just quickly go over a few logistics. To eliminate background noise, audio lines are being muted during the event. We'll have a moderated question and answer session following the presentations today. You can submit a question online at any time by clicking on the Q&A icon at the bottom of your screen. The event is being recorded. It will be shared publicly on bettercareplaybook.org, and you'll also be able to download the slides and watch that recording. Finally, at the end of the webinar, you'll see a brief online evaluation that will pop up on your screen. We really encourage you to complete that and appreciate that feedback. We can go to the next slide. And welcome everyone who's just joining us. I'll quickly walk through our agenda next and share some background on our wonderful presenters we have with us. So today we're focusing in depth on the Neighborhood Nursing Program. This is an innovative community-based primary care program, first piloted beginning in January 2024 in Baltimore. On today's event, we'll first hear from Asaf Bitan, Executive Director of Ariadne Labs, who will share insights on the evidence base for the Costa Rican primary care model that serves as an inspiration for neighborhood nursing, and who will also share insights on opportunities for this kind of primary care approach in the United States. Next, we'll hear from the neighborhood nursing team who bring experience designing the pilot and implementing the program, and who will share more about how they've applied that evidence to design the program, how the program is developing structures to care for individuals with complex health and social needs and those with rising levels of risk. They'll talk in depth about the roles of nurses and community health workers in the program, and also speak to insights on the financing challenges and the opportunities for really sustaining this kind of innovative and all-in approach that cares for people covered by many different payers. And then finally, we'll save quite a bit of time for Q&A at the end. We received a lot of excellent questions ahead of time, and we'll also answer questions shared during the event. So we can go to the next slide. And for those of you who might not be familiar, the Better Care Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. So every month, the playbook summarizes new evaluations, journal articles, tools, and also develops resources like this webinar that are really designed to translate evidence and research into practice. And you can explore the playbook at bettercareplaybook.org. On the next slide, the playbook is funded through the generous support from 7 leading national healthcare foundations, which include Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. And next, I'm pleased to introduce today's presenters. We'll first hear from Asaf Bitan, Executive Director of Ariadne Labs, which is a health systems innovation center at Brigham and Women's Hospital and the Harvard T.H. Chan School of Public Health. He is a practicing primary care physician, expert in primary healthcare policy, financing, and delivery. And Dr. Bitan and Ariadne Labs have extensive experience researching and partnering on the ground with Costa Rica's universal primary care model. And then the team at Neighborhood Nursing includes Sarah Zanton, who is a serial idea entrepreneur and dean of the Johns Hopkins School of Nursing. She co-developed and led research and scale of the Capable program for older adults, and now is working to develop neighborhood nursing, a potentially transformative model of care. We'll next hear from Tiffany Reiser, who is a nurse practitioner, PhD candidate at Johns Hopkins School of Nursing, and former home-based primary care program director. She works to promote home-based and community-based interventions for older adults to improve function, enhance social connection, and promote aging in place and in communities. And Terry Lindsay is a dedicated and certified community health worker with over 5 years of experience at Sisters Together and Reaching. Terry has also served as an advocate and paralegal with Disability Rights Maryland and Disability Rights California, leveraging his skills to assist individuals in championing their rights. So on the next slide, we I'll just note, we'll really welcome your questions throughout the webinar. And so we'll do our best to answer those. And next, I will hand it off to Asaf Bitan. Welcome.
Thank you so much, Logan. And it's really such a pleasure to be here with you all. Good afternoon, good morning to those of you on the West Coast, so in the Alaska Pacific regions. This is a wonderful opportunity to just share with you a little bit about a journey that Ariadne Labs has taken in partnership with colleagues in Costa Rica. For this coming year will be our 10th year together. It's been a journey around learning from and with them around a very special system in a special country that has, over the last 3 decades, taken the time, effort, space, and resources to partner and produce one of the best primary healthcare systems in the world. You don't have to take my word for it. What do we mean by best? We, in the next slide, and by the way, that's a picture of some of the folks that we've had the privilege of visiting in their house on community health worker home visits. But, Costa Rica has between the 2nd and 3rd highest life expectancy in the Western Hemisphere. It has a life expectancy that's quite frankly above the United States right now. And it has a healthier population than the United States, despite a much more an economy that's sort of not as expansive as the U.S. and healthcare spending that is nowhere near the U.S. So in the U.S., we spend between $12,000 and $13,000 per person per year on healthcare, and we get often middling, inequitable, fragmented outcomes. In Costa Rica, they spend about $950 or $60 per person per year to produce not just life expectancy that rivals Bermuda and Canada, but really chronic disease control, prevention, maternal health outcome, vaccination, and integrated care outcomes that are really a model for the world. We at Ariadne do a lot of work on global primary healthcare, and what I can tell you is that in the comparative frameworks at the WHO and with the Primary Healthcare Performance Initiative, Costa Rica consistently ranks amongst the top 3 or top 5 primary healthcare systems in the world, and probably unequivocally the top primary healthcare system in the low and middle income country distribution. So how is this country producing such outcomes? Next slide, please. Well, what is happening and what we've been, again, it's a decade-long engagement. For those of you that like to read academic papers, here's a paper from 2017, but let's just talk about it sort of in the nuts and bolts and in the bottom line. Costa Rica has not done this overnight. It has not done it through one political party or one political part of the spectrum. It has done it sequentially, the hard work, first starting in rural areas and then moving to urban areas, and really doing 4 things in a pretty unique way. Now, I should back up and say Costa Rica is a fairly unique country in the sense it's about 5 million people, quite varied topography from beaches to volcanoes to rainforests to dry areas. We talked about it's a middle-income country. From a healthcare perspective, they have not always been this avid in terms of their healthcare system and performance. But what they did starting in the 1980s is they did something very interesting. They merged their payment system with their delivery system, which means that they have a central payment and delivery system for the public provision of healthcare, which is the vast majority of people take part in. There is a private sector, but it's relatively small. And what's called the Caja, which is the sort of combined insurance and delivery mechanism has an incredible data system and a way of and a mandate and a public oversight body to reach every person in Costa Rica, regardless of their citizenship, their migration status, their regionality, locality, race, or ethnicity. That is their mandate. And so the four things that they have done to really push forward an incredible system and things that we can think about and that I see inspiration in the wonderful model that you'll hear about forthcoming in Baltimore is they've done four things. Number one, they do what's called geographic empanelment. Every person in a defined area, about 4,500 to 5,000 people, is assigned and enrolled with a primary healthcare team and knows that that's their assignment. So we'll talk about that in just a little bit. Those teams are called EBAIS teams. EBAIS stands for, in Spanish, basically basic comprehensive healthcare teams, equipos básicos de atención integral de salud. So they are known as EBAIS teams, and they're the sort of central way of interacting with the healthcare system. And they meet people both at home and in clinics. They're not just clinic-based. Third, these teams and their mandate incorporate more than just medical care. These teams once a year see every single person in the country, or try to, and they reach like over 95%. They see them not just to check what their health conditions are in preventive screenings, but also to assess essentially what we would call in the US their social determinants of health or their social drivers of health. They have on now iPads that are geo-linked, so they know where everyone lives. And in the questionnaires on the annual visits, they mark things like, does the house have running water? Are the floors concrete, wood, or gravel or dirt? What is the roofing like? Is there access to sufficient food? What are the screens for domestic violence? Do they have transportation issues? Some of the people that they see, and we've done home visits with them, may live in a valley in a rainforest that takes half an hour on an ATV crossing 3 streams. That's a real story to get to. Others may belong to indigenous groups in the South that live between the Panamanian Costa Rican border and have no one place that they call home. And so they're reached at wherever they are in their seasonality. So this integration of public health and medical care is really, really important. And the fourth thing that they do is that they have an incredible measurement system and accountability mechanism that allows them to not only know how teams are doing and how their populations are doing, but also to hold managers and politicians accountable for the performance. Next slide, please. So these EBAIS teams, and this is a graphic from one of our reports that we built with them, it really are based on this community-based empanelment, this idea that everybody in a defined community geographical area has access to the team. The team includes, at minimum, what we call an ATAP, which is a word for an acronym for community health worker, redes, which is a person who does intake, data forms, epidemiological surveillance, pharmacist that dispenses medications in the clinic that's associated with the team, a physician who reviews care plans, does acute and chronic care, and a nurse that does key nursing functions that span from home-based nursing to treatment of acute illness to supporting chronic conditions to vaccinations and other preventive care. These EBAIS teams are gatekeepers to secondary care and are where the locus of data flows and is organized. Next slide, please. So the organization is really interesting here. So you see a map of all of Costa Rica on the top. Costa Rica's healthcare system is divided into these 7 large health regions. So if you take a region in the west part of the country called Chorotega, you can see in the middle graph, that's a map of that health region. Each health region is divided into health areas. Health areas might be about 15 per region. There are about 104 total. And in the bottom map, each health area is divided into an area for which one or more EBAIS teams are responsible for the people in that area, regardless of if it's in the capital city of San Jose, big city or if it's in a very rural area. Those teams also define the management and data structure because the managers of the health areas get ongoing data through an integrated electronic record that's integrated with the medical record that includes specialist primary care and inpatient records and imaging, as well as the social record. People's, again, we talked about their social drivers of health, their social security needs, their poverty status, et cetera. So that it lives in one record that the Costa Ricans have spent about 10 years building. And just as an example of what this record can do, it's stuff that we would dream of in the US. I went on a home visit in a very poor area within San Jose, the capital, and it was for a woman who had just had a stroke who was discharged from the hospital. Please note, the woman was an undocumented migrant from Nicaragua, and yet she was in the system and cared for by the system, regardless of her citizenship status. The discharge information was available to the community health worker on her iPad that had the geolocated area of where her house was and enough information to literally say in Spanish, make sure to go into the back door, not the front door, because the front door has a bit of a mean dog that often barks. So if you knock on the back door, you probably won't get bitten by the dog. I mean, you know, this is about really community health and community health workers and a system knowing the people that it cares for and accompanying them on their way. But it also includes data like, hey, you know, you were just put on a statin and aspirin after your stroke. Are you taking it? It didn't look like you filled it at the pharmacy. Can we help you fill it? And here's your recent blood pressure and how can we do better on it? So this continued data monitoring and feedback is fascinating because in my final minute, what they really do is they look at all the performance of the health areas at the management level centrally. And if a health area is not performing where it should be, two things happen. It's either they tell us a management issue or an equity issue. If it's a management issue, then they replace the management. If it's an equity issue, i.e. the area is poor and under-resourced, they pour in more resources, more EBAIS teams, more workers into the area to help the community meet the health targets that are supposed to be equitable for all. It's something we could really learn from a lot in the US. And in my last slide, what I can show you is that the long-term effects are profound, and we rarely see this and see documented evidence of this. This is a very in-depth paper done in a health economics journal by a combined team of one of our clinician researchers, Maddie Pesic, and Dr. Maura Garcia and others at the business school in Costa Rica. And what it shows that 9 years after expanding this model with a primary care center and EBAIS teams, after controlling for as many factors as possible in this incredible data set, there was associated declines of 13% in age-adjusted mortality of people in the assigned areas that got access to primary care compared to people who didn't have access, because this didn't all start overnight. It was a slow expansion over 20 years. And the effect was highest amongst adults over 65 years of age, with non-communicable diseases such as hypertension, hyperlipidemia, diabetes, and stroke. That's where the benefit on a population mortality level is happening. And it's exactly in line with what the model is trying to do, because we've seen it and documented and written lots about it. And there are videos, you know, that we've produced just to try to show how this is happening and the incredible results. And so in my last slide, if you're interested in seeing or reading more about those videos in the next slide, you can go to our website and I think it's one more slide over, please. And you can go to that website right there and take a look there. We have a 5-minute video. You can see the community health workers doing incredible things. Like there's a community health worker who is in charge of seeing patients with differential abilities in their area. He drives on his ATV miles and miles every month to go to see homebound residents who have, let's say, cerebral palsy, who are taken care of by their families so that they don't get institutionalized. And he visits them every month to make sure that they have what they need. I mean, it's incredible, incredible work. And I think you'll see the tie to some of the incredible work that our friends and colleagues in Baltimore are doing. So thank you for your time.
Thank you so much. That was fascinating and really exciting to learn more about that evidence. And I'll turn it over next to the team at Neighborhood Nursing. And so I will pass it off first, I believe, to Sarah Zan.
Yes, thank you so much. And Terry and Tiffany, feel free to put your cameras on now or later, whenever you're ready. So Asaf, thank you so much that you couldn't have done a better job setting up what we're trying to do. And if people are going to fall asleep after my first slide, I'll just say, if what you can walk away is, we're trying to see, can Costa Rica work in the US? And we think that with new policy implementations that it's possible. So next slide, please. Okay, next slide. That's essentially what I just said. Okay, next slide. Okay, so let's just think. So Costa Rica has been doing this since the 80s. They're clearly much better developed than we are in terms of this. But as we started to think about whether, particularly starting in Maryland, we could implement the Costa Rica experience, I wanted to start with the very end in mind, not just the Costa Rica end in mind, but like, why do we have a health system? And some of the things that are important to me and to community members and people I talked with are equity, as Asaf mentioned, for people to be free from suffering, to experience joy, to be able to participate in whatever is meaningful to them, for it to cost less, because as Asaf mentioned, we spend so much more money than any other country, and we have the worst outcomes, and for it to be trustworthy, that currently not everyone trusts the healthcare system. Next slide, please. So when I initially thought, I had read about Costa Rica and had, like many Americans thought, oh, well, that'll never work here. But as I was actually sitting on the front porch with my son one day, and he basically made it sound like he didn't have any access to healthcare. He had a question he wanted to ask at a plasma donation center. And I said, what? And he repeated it. And I started to think, wow, if he feels that disenfranchised, and he has all the privileges that this country can give anyone, including a mother who's a nurse practitioner, then what about everybody else who feels that disconnected? And I started to think about Costa Rica and whether we could do it here. And so just one example of a model, we've been moving towards population health since the 80s, really, in various increments. And one of the exciting new CMS models is called the AHEAD model, where the idea is to put a cap on global spending for hospitalizations and put it into primary care. And as we started to think about this, thought, well, why don't if we could do this geographic empanelment with the teams that Asaf mentioned, that we could say real primary care isn't just who comes into you to the clinic. A real primary care strategy would be a geographic approach where everyone, if they're homebound, if they're homeless, if they're scared to come in, if they do come in, everybody has access to this prevention. So next slide, please. So some of you may know Maryland has a different model since the 80s, different model of paying for hospitalizations. We have a healthcare commission that sets hospital rates, and we don't have charity hospitals, and all the hospitals pay into, all the insurers pay into a pool that covers hospitalizations. And so one of the thoughts is, well, if that commission could do the same thing for getting the insurers to pay in for population health. So next slide. So I've essentially gone through this. We don't have a pharmacist and a physician on the team. At this point, we have a nurse and community health worker who you're about to hear from in a minute. And the idea was we are a university working with other universities and community health worker organizations, and don't have the ability to say, ta-da, we're going to do the whole Costa Rica model. But our thought is get it going, get it started, get some movement behind it, and work fast to get the the policymakers to say, oh, maybe we could do that. So next slide, please. We also strongly believe that besides better primary care and some of the outcomes that Asaf Bitton talked about, the primary care shortage, workforce shortage could be decreased because we would do so much more prevention. The nursing shortage is actually not a nursing shortage. It's that our health system is wrong, and that we suck up so many resources in terms of acute care. It would provide stable careers for community health workers. Currently, community health workers are often grant to grant, where they get trained in something and then they can't do it anymore because it's not reimbursed. And so a model like this could create career ladders and career lattices for community health workers. For both behavioral health and the opioid crisis, we imagine that as this gets fully stood up, that both behavioral health issues and substance use disorder would be screened for, all the way up to harm reduction on a population basis. We also know that palliative care is often only referred to in the last 2 weeks of life. And imagine if you knew your nurse and community health worker longitudinally over time, and they suggested palliative care, that you would think about it, and you would think, oh, that's not hospice. I'm not about to die. I just need a different model. Really importantly, that the power dynamics completely change when you're in someone's home, and the amount of listening and seeing someone as a whole person, and that can lead to better trust. And finally, that in the current clinical system, a lot of times, if we think of patients, we think of a deficit model. They've got problems, they've got high blood pressure, they've got no food, they've had a stroke. And that when you see people in their homes as full people, it's a very different model that is important for both for trust and for health outcomes. Next slide, please. So Tiffany and Terry are going to give you a few stories. I'll just tell you that we're doing this in concert with Sisters Together and Reaching, Impact, University of Maryland, Baltimore, Coppin State, and Morgan State. And next slide, please. And what we started listening to communities last fall, in the fall of 23, and built an action structure between those community partners. We started in one neighborhood in Johnson Square in Baltimore in January of 2024. We've raised actually about $9 million so far. We've been on NPR, on the Trade-Offs podcast, the PBS NewsHour. People are excited about the idea, and the idea, the philanthropy will only get us so far, and it's going to have to start being picked up by insurers working together, or by the state kind of mandating it, or being part of the AHEAD model. And I think I'll stop there, and we'll shift to Tiffany.
Thank you, Sarah, for the setup and background. Hi, everyone. My name is Tiffany, and I'm going to be sharing a few stories with you that we felt exemplified some of the encounters that we're having in the community in Baltimore City, and help to demonstrate some of the needs that we've been able to address and intervene upon. So the first story I want to tell is about an older female client living in affordable housing apartment. And she lives with her daughter and her grandchild. And we met her at one of our walk-in neighborhood nursing community-based hub sites, where we're conducting a blood pressure screening event back in the spring of this year. She continued to visit our community site regularly for blood pressure checks, and has a history of type 2 diabetes, and amputation of one of her lower extremities, and end-stage renal disease on the verge of needing dialysis. Now, the property manager at the building, who was a former community health worker, let us know that this client had waffles and pancakes with syrup every day for breakfast, and really should talk with someone about her dietary habits. The client and I met to record a food log of what she typically eats for each meal. We then used resources on myplate.gov to review each of the food groups and talk about ways that she could reduce sodium, cut back on added sugars, and increase fruits and vegetables. After having a conversation about what she likes, what she'd be willing to try, and what she doesn't like, we used a tool called the Grocery Game Plan to write out a shopping list that she could use as a guide during her next trip to the grocery store. In summer of this year, I checked back in with this client, and she was excited to tell me that she had made some successful improvements in her diet, and so much so that her A1C had gone down from about 9 to 10 to about 6 to 7. And when I asked her, what made the difference in her life, she said it was us discussing her nutrition plan and making a grocery shopping list. And so this just demonstrates how you never know how impactful one conversation can be in motivating a person to make behavior change. I also want to share with you all a lovely story about a middle-aged gentleman who lived in the same affordable apartment community in Baltimore City in the Johnston Square neighborhood. He's a military veteran with a history of PTSD and hypertension. And we met him when he attended one of our health fairs led by a group of public health nursing students in partnership with our neighborhood nursing team, working out of one of our community-based hub sites. Now, he came just out of curiosity to see what was going on, and we happened to be giving free weekly pill organizers away that day. And after speaking briefly with us, he left and came back with a large bag full of pill bottles. He reported that he does not know how to fill his medication trays and would like someone to review these with him so that he feels more comfortable. And using a medication list provided by his PCP and his VA pharmacist, we were able to review these medications. And then, as a registered nurse, I observed and encouraged him as he filled the medication tray himself. After he completed this, he hugged me. He became slightly tearful and he thanked me for the time. And we met again to do this together one more time. And again, I observed and encouraged him throughout the process. And this just demonstrates, the importance of promoting self-efficacy and improving this gentleman's confidence with managing his own medications. And the last story I want to talk about is one that touched Terry and I as we both worked closely with this client. And it's about an older female living in HUD housing. She attended one of our blood pressure screening events at one of a different community hub site in the Johnston Square neighborhood. Upon checking her vitals, I detected that her heart rate was irregular, low to mid 40s. She reported that she had been having chest pain and told this to her cardiologist, who had advised her to go to urgent care. Now, this was 5 days ago, 5 days before at this time, and she had not gone. So I called 911 and I called her cardiologist to give report. The client agreed to have her son drive her to the nearest emergency department. And it turns out that she had a coronary artery obstruction and required the placement of 2 stents. The next time the client came to our community hub site after being discharged, she brought her 6-year-old granddaughter with her. She informed us that she needed help getting her enrolled in school. The little girl had been couch surfing and living in a car with her father. Through our partnership with East Baltimore Medical Center, a local FQHC that's located just about a 15-minute walk from where she lives, we were able to connect her with a pediatrician who was able to then schedule an appointment to see her later that week to update her childhood vaccinations. The vaccinations are what were keeping her from being eligible to enroll in school. The pediatrician also detected that the child's teeth were in very poor condition, and she required a dental referral to treat an infection. The following week, this child was successfully enrolled in elementary school, and the grandmother continues to take her to school every day and reports that she loves going, but sometimes gets in trouble for talking too much in class. This is an example of how building trust with the grandmother, who was somewhat of a gatekeeper for the family, opened up an opportunity to help other members of the household with issues such as health and education. This also demonstrates how having trust with your nurse and a community health worker in a place that you're comfortable with receiving care can really make a difference and can translate to getting access to care, even in the context of someone who is insured and who does have a specialty care and primary care provider in tow. So after those lovely stories, I'm going to hand over the mic and transition to my friend and partner, Terry Lindsay.
Why, thank you, Tiffany. It's going to be sort of difficult to follow that up. So, but as stated earlier, I've been a certified community health worker for 5+ years. I've also been an advocate and a paralegal at 2 nonprofit law firms that focus on people with disabilities. So when I came to this program, I had some knowledge of some backgrounds in Social Security, Medicaid, and things of that nature that assisted me with assisting the individuals we're trying to help. So one of the first people I like to talk about was a young lady who had a wheelchair that was just tore up. A doctor had ordered her a wheelchair. She kept calling the doctor. Matter of fact, one time was on the phone with her, called the doctor, and nobody knew what was going on with the wheelchair. So I took it upon myself to go up to the hospital where the doctor was to find out what had happened. And it was simple. Nobody had sent the order in to get her wheelchair, but every time she called on the phone, she was getting a runaround. So once I went up there, and explained who I was and what I was trying to do, somebody found the paperwork. They submitted the paperwork, and I think maybe like 5 days later, somebody came to the apartment complex with a brand new wheelchair for this young lady. And also in assisting her, by her being a wheelchair user, the way the mailboxes are set up at the building that she resides in, her apartment number meant that her mailbox was on the very top of all mailboxes. And she didn't really have access to get these to her mailbox. So she had asked about them moving her mailbox down lower, and they said, no, your mailbox has to correspond with your apartment number. So, like I have some background in putting together reasonable accommodations requests. I put together a reasonable accommodation request for her to sign and put her name on it and submit that so they could move her mailbox down to where she can access it. And now she doesn't have to hang out in the lobby asking people to get her mail for her. Another individual that we met when we first started, this person came down to get a blood pressure check. And I think that's how the two of us work together. The nurses were pulling them in with free blood pressure checks, and then I was able to follow up to see if they had any social determinants of health that they need to be addressed. So he's taking his blood pressure. He said he had blood pressure medicine, but he didn't have any money to get his blood pressure medicine. So I followed up with him. Come to find out, he had lost his wallet. He had no ID. He had lost his Medicaid card, his some other identification cards that he needed. And it was a slow process, but I was able to meet him at the Social Security office, and we were able to submit paperwork for him to get a Social Security card. Then he also was referred to the same clinic that Tiffany had mentioned, the East Baltimore Medical Center. And we got paperwork from there, and we were able to go to social services and get his Medicaid card. So now, as a result of that, now he can get his paperwork completed so he can get an interview with Mobility Transportation in order to access mobility transportation so he can get back and forth to his appointments. Stated earlier, I guess there's not a quote unquote a doctor assigned to the team, but the neighborhood nursing program, we have gone to community meetings in the neighborhood, and we found out that there's a doctor that attends the community meetings. And as far as the neighborhood nursing program is concerned, he is real accessible to us. We could call him directly today. He might get back to us later on, and normally we can get a appointment scheduled like within the next day or two to for the people we're trying to serve. So I mean, there's plenty more stories. I don't want to take up your time with all the stories, but like this is a great program, and Sarah needs kudos for implementing the program, and the neighborhood nurses and the community health worker, we go together like peanut butter and jelly. So it's a great fit.
And thank you, Terry, and thank you, Tiffany. There may be many people listening who are thinking, well, I do stuff like that. And there's so many wonderful community-based programs in the country. And I think where we're trying to go with this is to get towards universality. That everybody not a certain age, not a certain complexity, not a certain end of life, not just because you've been discharged recently, but more towards what Asaf described in Costa Rica, where you're looking at it from the top and seeing and looking at areas. And so we've started with Johnson Square, which is a small area. Soon University of Maryland School of Nursing is going to be starting in Sandtown, Winchester. We've got money to start in a suburban area and a rural area in Maryland. And our thoughts are that we'll keep going with philanthropy, and then we're started talking to insurers, some of whom say, well, I would like to do that, but I can't subsidize, my competitors. So if you think about a block, or even just a family, someone might have Medicare, someone might have Medicaid, someone's got Humana, someone's got Aetna, but right now we send nurse practitioners in, not we neighborhood nursing, but our society, to see one person. You walk by everybody else, when the expensive part is to get there to the house. So we're just hoping that we think common sense will prevail, especially as these new policy tools like the AHEAD model makes it easier to really make revolutionary changes to primary care. And so we would like to stop there right on time to give a robust chance for questions and answers. And I just wanted to acknowledge the community members who've been working with us all along, who have been taking funders on walks and talking, and also just all of our great partner organizations. And thank you for listening.
Thank you so much, Terry, Tiffany, and Sarah. We'd like to invite all of the presenters to come back on camera to answer some of the great questions that we've been receiving. If you have a question, we encourage you to share that in the Q&A box at the bottom of your Zoom screen. We've been receiving some great questions, and we also received some great questions from registrants prior to the webinar. So I would say that the topic that we received the most questions about from registrants had to do with funding and sustainability, right? That is top of mind for many. One, I think, really interesting question that an audience member shared was, what are the key metrics that you're thinking about and thinking about gathering that will help to inform conversations around sustainability? Welcome, Sarah, if you'd like to start there.
Sure, I'll start. Others can chime in, and Natalia, feel free to unmute as well. Well, when we started making the key metrics, there were just pages and pages and pages, because there's so many implications for doing this well. I think the bottom line metrics are hospitalizations, ER visits, 911 calls, ultimately mortality, vaccination rates, school readiness, some of those larger societal ones. And like many other states, Maryland has a good health information exchange where it's easy to pull from to see almost everything that I just mentioned. I do think that beyond those and beyond disease specific things like hemoglobin A1C being more in control, for example, that there are other layers as well. There's societal layers. I think that there will ultimately be more trust, as we've discussed. And if a whole block has the same nurse and community health worker, people come together. We've seen that already in Johnson Square. People are taking walks together who hadn't been going outside together. So I think there's societal outcomes as well, besides the individual clinical outcomes and clinician outcomes. If you think about the nursing shortage, is not a shortage, as I mentioned. It's a shortage of jobs that people want to have, essentially. There are a lot of nurses who don't work in acute care and who think that that's all there is to do. As we develop roles for nurses and community health workers that are meaningful and preventive, and people know people over time, that is also another metric. But the short answer to that is really just some of those higher level kind of the things that cost money to insurers.
Thank you so much. Any other presenters? Feel free to unmute if you'd like to add in there.
And Asaf, feel free to riff off of what you think Costa Rica's outcomes are in terms of what you think ours could be.
Well, I think the key part is to me, the adage about primary care. It's what I like about the program that you're doing, and it's deeply integrated with the community. It's not done to the community. There's a long-term time horizon. Sometimes we talk to payers and to health systems, and they get reminded about the value of primary care and home-based care, and then they want to put some mild investments over really short timelines. And
Mhm.
there's pretty much no evidence anywhere in the world that you can sort of quickly manufacture primary care in 12 or 18 months and get
Mhm.
a return on investment. It's a long-term relationship-based enterprise that works with people, doesn't do stuff to people. And the biggest thing that I can say from both my work, I work at a community-based primary care clinic, and from my work in these different countries, is it takes time, data, and persistence, and there are no shortcuts.
But I think a great point that you kind of tangentially mentioned that I'll just call out is it's hard to get an insurance company to do something that's not going to have immediate benefit, which is what you just said. But if we can do this all in, then maybe, Humana's dollar today is saving Aetna's tomorrow, but Aetna's dollar today is saving Humana's tomorrow. Do you know what I mean? Like if there was
Yeah.
trust that this would last and that everyone's all in, then that having immediate results doesn't matter quite as much, because if people are switching programs, it doesn't matter as long as it's reciprocal.
Yeah. And where I would slightly not even differ, but I've in our policy discussions, and what I say to payers is, it's a bit of a radical statement, but don't invest in primary care to save money. I don't actually believe that there's a lot of evidence that investments in primary care will save money in anything short of 7 or 10 years. And I actually think it's absurd, nothing that you're saying, but I think it's absurd that payers sort of put a level or a bar of evidence on primary care investment, community primary care investment, as like, well, you got to save money. But then, so I tell them, so how come when you bought that PET scanner, you paid for that MRI machine, or you pay a surgeon gazillions of dollars to do great surgery, love surgery when you need it, but why is that same bar not put on on those services? So I would refuse to go down that logic. Now, what I can say from the evidence and from the policy work is you have a really good bet with investing in community-based primary care to get better outcomes, better equity at the same cost. So that's, to me, smarter spending. Spend the same money on better stuff and help your community. And the National Academies report says that's a summary of evidence. I mean, but when we make these promises, as frankly, like I used to when we started some of the medical home movement work 15 years ago, we said, oh, we'll save you guys a lot of money. They're like, great, 18 months. And then it didn't happen in 18 months. We got ourselves into a trap. I don't want anyone to promise that, because I think that the care that you're providing and the stories that you heard today and the data connected to that stories is more than enough to justify higher, better, and more sustainable spending.
Love that.
This is a great conversation, and we've been getting a lot of great questions. One other area that we're getting a lot of questions about kind of connects to the RN and CHW roles, and kind of how you landed on those two roles being a part of the care team dyad. Questions about how you respond to kind of how you define the program to those who might be hesitant to do the work without having a prescribing provider on board. So if you can speak a little bit to the kind of the thinking behind that dyad and a little bit more about those RN and CHW roles, that would be great.
Sure. Well, I'll just give a quick start, and then Tiffany and Terry, feel free to jump in if you would like. So, community health workers are magic. They're wonderful. They're super impactful. I can't say enough good things about community health workers. I also think that RNs are really underused in primary care, and that RNs can add a layer of understanding how the biology fits with the psychology and the medications, and all the training that nurses have. We know that there's been a lot of really interesting work inside primary care clinics of trying to explode the RN role so that they can do some protocol-based chronic care management and vaccinations and some of the other kind of preventive public health that we are just aching to move out into the community, including opioid treatment, opioid harm reduction treatment. And so to me, the combination of the two is fabulous. Yes, it would be great to have a social worker and a pharmacist and a doctor and a physical therapist and occupational therapy, but at some point you need to figure out the team that is kind of the most mobile, the most accessible, in terms of what you're thinking. And I do think that over time, some things will probably be added. I was talking to Tom Lee, who started One Medical and now Galileo. And if they get a big panel that has a lot of substance use disorders or behavioral issues, they'll have a community health worker and an LCSW instead of a community health worker and a nurse. And that I do think there's plenty of room for figuring out the optimal teams. We've just started with an RN and a community health worker. And Tiffany and Terry, feel free to add to any of that if you would like.
Just wanted to say that, as you mentioned, Sarah, there's so much room for expansion in terms of the disciplines that can be incorporated into this community-based model. But as you could hear from all the stories that Terry and I talked about today, none of them required prescribing. That's not what people needed at our first glance, right? These are needs that a nurse and a community health worker could be able to address and then get that person to the next phase, as all these individuals were insured, but they didn't have kind of that step before that. So I think for where we are, it's appropriate with the connections, but of course we want to expand to grow the program.
Yeah, and another thing is based on trust and building the trust to the people that we're trying to serve. So a person might come down, get a blood pressure check, might talk about an issue, see them next week, they come back for a blood pressure check, they're willing to talk more about their issue, or they bring another issue. So it's just building trust and faith. And so, at first when we were there, we were trying to pull people in. After a couple of weeks, people were coming looking for us. Say, well, I thought you were going to start at 8:30 instead of 9 o'clock. Or will you be here next week? Next week is a holiday. So, it's all about building trust and talking to people like they're people. You don't look at them as a client. I don't look at them as, someone who needs my assistance. I'm looking at them as somebody who, may have something that we can just address right then and there. So that's how I look at it.
Sarah, go ahead.
I was just going to say that we see it as a continuum of social, emotional, biological, physical care that an RN and a community health worker can kind of cover the water together.
And Logan, if I could jump in really quick and just so
introduce
folks
yourself
know.
quickly.
Yeah, I will.
Okay.
I'm Natalia Barolin. I am Senior Health Policy Advisor here at the School of Nursing, also a nurse, have worked in a federally qualified health center and done health policy and comms work. But and work really closely with Sarah, the neighborhood nursing team, as we try to grow the model, expand and get buy-in and political will to support something like this. But one thing I wanted to say in terms of the RN and community health dyad and the importance of that, I think, and how it works so well in Costa Rica is having that clinical extension piece also helps support our brick and mortar practices, right? It relieves pressure on our primary care practices. It relieves pressure on our health system in our hospital and acute care settings, and relieves pressure on the workforce. So you get, when we think about measurement and benefit, to Asaf's point around getting more for your money. Like maybe we're not saving, but we're getting so much more for your money. There's also this domino and trickle effect across the system that we can see that is also supported by having this clinical expertise in your RN, and then the community health worker who's really embedded in that community is helping to build that trust, understands those needs in partnership with the RN, and doing that work together. I think that's what's particularly unique here too about this dyad.
And I noticed there's a question about the faith-based nurses, and that is a plan of ours to start working with them more and thank you for raising that question.
Yes, there's been some really excellent questions that have been posed in the Q&A. I think we unfortunately won't get to all of them, but I wanted to just close with, for all of our presenters, there was one great question we received, which was sort of the potential role for these kind of models to build trust and resilience within communities. And Terry, I think you just were speaking to this, but would welcome each of you to take 15 to 30 seconds to speak to that before we wrap up.
Well, me personally, no, when I meet an individual and I find out that I can assist them, I never promise them anything I don't have control over. The only thing that I promise them is I will do my best to try to assist them in getting the services that they need or the services that they want. And if it's something I can't, do myself, if it's more medical, I refer them to Tiffany. If it's something that Tiffany or I can't address right away, then we go to outside agencies that we have made connections with to bring into the building to provide services. So for me, it's all about trust and contact, just staying in touch with the individual.
And I'll jump in. In a typical patient chart, back in the day when it was paper, you would open it up and you would see all the problems on the left side. They've got high blood pressure. And then you'd say, what are you doing about that? And it was just completely problem-based. And a huge part of this model is person-based. And what are their goals? What are they trying to do? What matters to them? Not just, what's wrong with you, and never leading with what. And Senator Sanders, Bernie Sanders, came to visit in Johnson Square, and one of the participants said to him, I have Medicare and I have a doctor and I have high blood pressure and I never go, but I see these nurses because I trust them and they're here. And I think those two things, that we are where people are and we're trustworthy, and including nurses and community health workers, it makes it an entirely different experience than needing to get dressed up and going to some big building that seems untrustworthy.
And speaking specifically to the community resiliency piece, I mean, part of what we did was we went in there and we talked to the people in the community first and said, what do you want? And, they told us, don't come knocking on our doors. We don't know you. We don't trust you yet. And that was how we developed these community hub spots where we started to see folks. Now they expect us. Now they're looking for us. They invite us into their homes. The community we're in Johnson Square also wanted more activity and socialization and physical movement. And they shared with us what some of their needs are. And the neighborhood nursing team helped create it, but it's really community built, community led. And we brought some of the infrastructure and resources for them to be able to do it. And this is something that now has built social connections and can live long beyond neighborhood nursing and is really owned by the community. And so it's not just those individual pieces, but going into those communities, identifying what their strengths are, what their needs are, and helping them execute on some of that and giving them the resources and the self-efficacy to be able to do that on their own. And I don't know if Tiffany wanted to add some thoughts to that too.
Just quickly say the unique aspect of being embedded within a community is you learn all the different moving parts. And so we didn't even get to speak about how we've sent patients to the church because the church has a technology class, and how we've sent people to the local neighborhood farm to get produce because we have knowledge of the produce giveaway program that they hold. So it's being able to connect all of these different pieces together, and that helps to build a stronger community.
Yeah, I mean, one of my patients tells me all the time, nobody cares what you know until they know that you care. And I think that what we're trying to do here all together and in our different ways, what the Costa Ricans are trying to do, and what the heterogeneity of the U.S. healthcare system says, that there is no one model. But if you show up you know, let's not get too academic about what trust is. Trust is you do what you said you were going to do. You show up when you said you were going to show up, and you help people, and you offer a space and environment where people can share their biggest fears, worries, concerns, and celebrations. If you have those things and you do it in there, you're welcomed into people's houses, you've been deemed trustworthy enough, or you're seen in a clinic because people want to go see you and you offer something of value to them when they need it, great things happen. It can happen through nurses. It can happen through other team members. It can happen. It almost always happens through community health workers. There's no one model. You fit it to the community and to the health system, but then you also don't say and don't allow them to say that, you know, your program has an ROI measure on it, but some other thing for glassy hospitals that are beautiful in the center of the city don't have an ROI. It should be flipped. This should be the layer and level of investment. And there are lots of ways to get there to build the trust that's necessary.
I love that. We're going to bring you everywhere we go.
Mic drop.
And I'll think of a better note to end on. I know we've gone a couple minutes over, so we'll just really quickly share a couple follow-ups. And I encourage those of you, you know, we've been trying to answer as many questions as possible. That includes some questions about other US-based examples, international examples that I think can be informative. So I encourage you to check out that information, as well as some payment, kind of understanding the payment landscape as well. So we welcome submissions to the Better Care Playbook. We really appreciate the opportunity to publish the work that different playbook audiences are developing and publishing. So you can submit that there. And I'll just go to the next slide. Really just thank everyone. As a reminder, please fill out the evaluation survey. We really, really appreciate that feedback. And thank you again to Terry, Tiffany, Sarah, Asif, Natalia, for sharing all of your expertise and insights today. I also want to thank the Seven Foundation Collaborative for supporting the webinar. And thanks so much to everyone who joined and shared your great questions. We hope to see you at another Playbook event soon. Take care and have a great
Thank you for having us. Really a pleasure.
Thank you
Thank
for your
you.
time.
Bye-bye.
Thank you. Bye.